Welcome to the Vatech Weekly Webinar Series, April 29th edition. This education series will be broadcasting Wednesdays, noon Eastern Daylight Time. We've been broadcasting since April 1st. I'm Jim Mayer, Education Team Manager with Vatech. Have the pleasure of working with Paul Satone, who's broadcasting live out of Las Vegas. Welcome, Paul.
Thanks, Jim. Great to be here. Really excited to have Dr. Miles here today. Where I'm in Vegas, he's down in Phoenix, and we're about to hit the 100 mark today, which is kind of a milestone every year. So getting the sunscreen ready.
There you go. Yeah, we've got some pretty good weather here in St. Louis. We've still been quarantined, doing our best to stay positive and productive. Like I said, we are going to bring Dr. Dale Miles on here in a few minutes. In the past, we've had a lot of questions on what do we want to be presenting in our webinar series, and anatomy was a big thing. We've got a lot of doctors who are looking to move from two-dimensional imaging into the CBCT and 3D world. With everyone's feedback, we've worked with Dr. Miles, and we're thankful he's going to be here today to go through our session. I did want to point out that we have hit the 1,000 registered mark for today's session, so we have a little over 1,000 people registered for today's session. Thank you everyone who is returning, and welcome everyone who is new to our session. Paul, what do we have coming up as far as in the next few weeks?
We got some great more sessions coming up next week. Continuation with Dr. Miles, identifying anatomy and CBCT. The following Wednesday, May 13th, we're going to be talking about kind of getting back to the new normal, complete health dentistry, the big paradigm shift that we're kind of going to face. And then May 20th, session 8, we're going to be talking about guided surgery and implants. We're calling it Tour the Guided Digital Implant Workflow. So we got some great stuff planned.
And I want to thank everyone for everyone's feedback. We did a couple surveys here the first couple weeks, and really these topics have come from our audience and what everybody has wanted to talk about. Paul, how do we keep giving feedback to Vatech and about these webinars and to Dr. Miles?
Well, we have our email, our ways to communicate. We have our sales at vatechamerica.com for any feedback on these sessions. Again, it's greatly appreciated. Also, our education email address for anything education related, software questions, etc. That's education@vatechamerica.com. And then anything customer support related, really easy way to contact support is cs@vatechamerica.com is that one. And of course, our website, vatechamerica.com. And then of course, Facebook, Instagram, our handles at Vatech America, and also LinkedIn. So lots of ways to contact us with feedback or any questions you may have.
Definitely. Thanks, Paul. Before we get started with Dr. Miles, let's talk about a little bit how we're navigating what the audience should be seeing, or everyone who's logged on should be seeing. You'll see myself and Paul at the top of the screen. Dr. Dale Miles will be joining us here shortly. You'll be able to see his screen. Off to the right-hand side over here, you can see a little orange arrow, and that's going to be your GoToMeeting kind of navigation bar there, where you can navigate through the session. If you're having any sort of audio issues, please either click on your help if you're using your onboard computer audio, or just go ahead and call in. This session is being recorded, and everyone will get a link to the Vatech Customer Learning Center, where this will be uploaded on Friday. So everyone will have a recorded session for this. Another thing to note is we are not giving out CE for this session. That will also be noted in the follow-up email with those links. This is a question and answer session, so while we're working with Dr. Miles, we can basically directly ask him a question, or if you have any questions for the Vatech team, you can type in your question box down here. I have my full education team, which will be doing a Q&A answer going back and forth for those questions. After the presentation, we're going to have a Q&A session from 1 to 1:30, or the top of the hour, down to 1:30 or so, maybe a little bit after. That's going to be with Dr. Miles, fielding any questions everyone may have. A little bit more about today's session. We briefly talked about this in the beginning. We're going to be comparing anatomical structures from the PAN to CBCT. Kind of where do we begin? So we're going to talk about film-based PANs to 2D digital PANs. We're going to go through some anatomical landmarks on panoramic images, and then how do they translate into the CBCT and the differences of what we're looking at, and how do we really easily navigate and make that transition into cone beam technology. Right now, I would like to introduce Dr. Dale Miles. Dr. Miles is a diplomat of the American Board of Oral and Maxillofacial Radiology and the American Board of Oral Medicine. Welcome, Dr. Miles. Let me get you unmuted here. Perfect.
I got me unmuted. I forgot to. I was so surprised to see this old face in the webinar that I didn't unmute myself. So, well, thanks for the invite.
Yes, thank you for joining us. We're looking forward to today's session. You've held several academic positions at several schools: Connecticut, Indiana, Kentucky, Arizona, Texas. The list goes on. Test construction consultant for the National Dental Examination Board for 7 years. You've authored over 130 scientific articles, 5 radiology textbooks, hundreds of invited presentations nationally, internationally, and we thank you for joining us today and working with us today. We're going to be reviewing your website for teaching dentistry, dentists, and auxiliaries about cone beam imaging. That's found at drconebeam.com, and you are in full-time practice of oral and maxillofacial radiology in Fountain Hills, Arizona, where I understand it's really hot today. And today, to date, you're a little over 28,000 scans.
Wow, that sounds pretty impressive. You know, I wrote that myself, so obviously, I'm just kidding. You have to supply a bio to all these meetings. I want to see by attendance if anybody's actually that's logged on so far has actually heard me lecture before. So we'll watch those numbers as we go. People can answer and say yes, because when I speak at a dental meeting, I ask that question, and basically I'm surprised. It looks like I've got groupies. You know, I have a bunch of people. And yes, it's going to be 105 here in Scottsdale where I am today. So we'll go to the presentation. What I'd like to do is walk you through the things that Jim told you we're going to do. So I have my objectives. I'm a dentist first. I'm a radiologist by training, and I did general dentistry up till 1999. So I did it 1 day a week in private practice in all the schools I taught in, but I'm really actually pretty knowledgeable about what everybody's doing in dentistry. So I have a different skill set. I'm a dentist first, radiologist next, and then I'm a recovering academic because I taught at 6 different dental schools over my career. Now I just read cone beam full time. So what I'd like to do, and I got to get my screen out of here as well. I can see myself on screen. Okay, I'd like to thank Vatech first of all for the opportunity to speak with the group today, and I'm very impressed with the numbers registered. I hope that you'll all feel very educated, or at least filled up by the end of the session. I'm actually doing more anatomy in the following session next week, and that will be strictly cone beam. However, today what we're going to do, we're going to try and understand the correlation of the anatomic structures that you folks are starting or have seen in your scans that you kind of question, you know, what is that? Or maybe you just scroll by it and forget about it. A lot of people do that, and unfortunately you can't do that. So what we're going to do, and I want to give a shout out or a thanks to Horizon Dental Institute. My computer crashed yesterday. I went to load upgrade to Windows 10 Pro. It wouldn't reboot properly, and it's still not rebooting. So I'm actually at Dr. Tom McClammy's Horizon Dental Institute in Scottsdale on their Ethernet connection because even my router at home, maybe it got some malware because it was kind of glitchy. So what we're going to do is we're going to look at, you know, what the differences are and what the anatomic structures appear like in both 2D pan and 3D cone beam. This is a conventional panoramic. This is a digital flavor, though it's not a film-based pan. And you can see that there's, it's a pretty good diagnostic quality. There are some things that maybe obscure data on occasion, like you see this white area across the right mandible. This is actually the ghost image of the opposite angle and body of the panoramic on this side. And these types of relative radiopaque, radiolucent areas actually don't exist much in digital panoramics. So, this kind of error we don't see a lot of. This is part of the spinal column that the patient is too far forward and they've narrowed these anteriors. A lot of this kind of positioning error and other capture errors disappear with 2D digital pan. And those of you who have already adopted that know. But it's unfortunate that some of you, after you graduate, forgot a lot of the anatomy that was in these 2D dimensional pans. So we're going to review. For instance, what I just outlined here in that light green area, and I'll bring it up again, okay, that's actually the zygoma, okay, and you can see here's the articular eminence, there's the condyle, those are pretty recognizable, but part of the zygoma comes down into the maxillary sinus region. The sinus is this area with other structures superimposed, but the zygoma kind of obscures part of the maxillary sinus. We also have, in this particular case, we actually have a mucus retention cyst. We have as you may remember the description, a dome-shaped radiopacity arising from the floor of the right maxillary sinus, and it too is in this region of the panoramic. So we've got a lot of structures that build up in this area. In a couple minutes, I'm going to show you the inferior turbinate, okay, on a pan, and we'll see what the differences are when we get to cone beam. So here is the turbinate, and of course, I don't have time to go through the principles of panoramic image capture, but structures in the midline sometimes are stretched out and they go from the midline area posteriorly. So the turbinate really doesn't look like this, except on a panoramic. We'll see what it looks like in a second. Also, those are called the concha, and there's inferior, middle, and superior turbinates. There's air spaces in between them and the nasal septum. We're going to see all this. The white arrow, hopefully most people will recognize that we're actually looking at the uvula, okay? The soft palate continues from the hard palate. We can see part of its shadow over the ramus, and that structure is actually the uvula. It's not very apparent here on this film-based pan, but we can also see the epiglottis. It's a little curvilinear, maybe even better on this patient's right side where my arrow cursor is going. And we can also see the hyoid. So there are some structures that we were able to identify on film-based pans. Now, when you get to the digital type panoramic image, the quality is much better. The actual image resolution is much better. The edge contrast is much better. And so we see many more structures. I mean, if you look currently now at the epiglottis, you can see it very distinctly bilaterally. You can see the hyoid bone. In some cases, I think we'll show you both arms of the hyoid, because as you remember, this is not a bilateral structure. This is a midline structure that actually, because of the capture, gets imaged twice. So digital pans are amazing. This is a typical one from Vatech that they've shared with me. They've shared a number of images, and I have a number of Vatech users, clients that I read scans for. And this is the type of quality that they're able to produce. I don't do much panoramic interpretation because most people that have 2D pan, they are comfortable with or think they know everything in it. But maybe we'll have a few little eye openers this morning. So the problem with any type of radiographic modality is if you don't know your anatomy, you won't find the pathology. That's as true on any imaging modality as you can have in dentistry. So I'm going to pose a question to you guys and gals, of course. I'm using the West Coast generic term guys, or East Coast, they say, hey, you guys, okay? Anyway, I hope you're laughing out there. Here is the area of interest. I've got a red circle around it. I'm going to bring it up a little bit bigger, but I want to know what you see, because I get referrals of 2D pans periodically, and they'll point at a little radiopacity that I'm circling here, and they'll say, is that a carotid plaque? Well, it's in the right location, but it's not. It's a normal anatomic piece of cartilage, and we'll tell you what it is. I've also shown this in lectures, and people have looked at this kind of bifurcated area in here, and they say, oh, that must be the bifurcation of the carotid artery. No, it's not. So what we have here is we have a number of structures in the airway area adjacent to the jaw and the pan. And you guys are all looking at the endodontics, how nicely it's been done, and reassessing the implant site. Well, over here is where you're going to find the systemic problems that you actually need to refer. So let's see what those are. I darkened it up a bit so hopefully it's looking great on your screens. But this structure right here, this oblong structure here, is the epiglottis. We got the posterior lateral border of the tongue, the epiglottis, and then part of the airway defined here, part of the oropharyngeal airway soft tissues. So that's epiglottis. This, of course, you all know is the hyoid. Okay, we can see one arm of the hyoid only here. The yellow area, believe it or not, is thyroid cartilage. Not the thyroid gland itself, but the cartilage. And this extension back here is called the posterior superior thyroid horn. Now that's what is suspended by a ligament. The thyroid cartilage is suspended by a ligament between the hyoid bone and this arm. So in between, there's a little radiopacity, and it's round, it's ovoid. It doesn't look like a, quote, diffuse sclerotic plaque that we see when someone has, at risk of hypertension or stroke. We're all attuned to that now. That's actually a little piece of cartilage. Don't go to sleep on me here now. It's called the triticious cartilage, and it's in many scans, but people mistake it for a carotid plaque, and then they have to pay a radiologist $75 to, for a report to tell them it's normal. So what you see in these regions on a panoramic, however, will look much different in the plane of section. Now, this is not a Vatech scan. I won't even tell you whose scanner this was, but sometimes we get some pretty poor diagnostic data, okay? And this is a small field of view scanner with several implants that we're assessing, and you can see there's absolutely no support for this implant in the anterior mandible. But as you're scrolling through your slices, all of a sudden you get to this little bifurcated area, and there are people that would look at that and think, oh my God, that's calcification of the carotid arteries, external and internal. No, it's not. This is basically the thyroid cartilage, but it's in thin section. We don't have all the structures piled up like we do on panoramic or cephalometric or even some of our intraorals. This is a 1/10 of a millimeter slice, sagittal view coming from the side showing the thyroid cartilage. And if you don't know it, then you have to sort of refer. So if you see with these things, you call them what you want to call them what they are. Call them an I don't know-ma, all right? And if you see an I don't know-ma, you need to refer. The standard of care says, oh, I don't know what I'm looking at, I better get it to someone who does. But if you know you're normal, you'll certainly cut down on the referrals that you might be tempted to make because you know your anatomy. Now, I've done a special procedure here. I don't know if it shows on the screen, but this is about a 5 millimeter thickness. I usually do this at 5 or 10 millimeter thicknesses, and I apply an MIP tool. In the software I have, I just click up there. In Vatech, they have an icon in the Easy 3DI. So you can click and get a MIP image, maximum intensity projection. And what it does is it makes calcifications more apparent. So we've got the hyoid bone here. We've got the thyroid cartilage with this posterior superior horn. And like I told you before, it's suspended by a ligament. Now this is a pretend ligament. I put it in there with PowerPoint, and that was to show you that there is suspension. Now, this can calcify as well. So the cartoon on the right is actually showing the anatomy of the thyroid cartilage, the posterior superior thyroid horn, the suspensory ligament, and the greater horn of the hyoid. This is an extremely important area of your scan data to look at and your panoramic. So why are we starting with pans? Well, okay, get out your pens and I want you to name all the structures that you see by number. Just kidding. Wish I could see the audience now. There are ones that you will recognize. There are some you will not recognize. Not every structure shows on every panoramic image because of errors of positioning, of all kinds of reasons. So it takes a lot of different panoramics to kind of show people what the structures are. So let's take one, for instance. Let's take this one. You already know that those are the hyoid bones. When we go to another panoramic, again, this is, I believe, yeah, this is one of the Vatech images. You can see bilaterally the hyoid bone, and it's up on the mandible. That means that the chin was too far down, so the hyoid relatively comes up on onto the mandible. And that is just a technique error that you can eliminate by training your staff. You can see the epiglottis bilaterally on each side, and you can see some of these other structures. So here's an image. This is a digital panoramic, unlike the conventional ones we've been showing you, and you can see both arms of the hyoid bone. We never had that quality before. We still, in this particular manufacturer's image, this might be Plan Mecca or somebody, you can see we still get some of these relative radiolucent radiopaque areas. So this is still white up here because it's the ghost image of the opposite side of the mandible. Now, in this particular image, you can see that most of that artifact is not visible. We can't really see anything that's interfering with our diagnostic quality. And if you look at this one carefully, this is the hard palate. This is the soft palate, okay, on each side. You can see the epiglottis on each side and the hyoid bone. You can also see some spinal vertebral bodies. Well, we don't have two spines. We only have one, but the panoramic projects it twice. If they're clear enough, I actually look at those areas for changes, especially if the patient might have osteoarthritic change in their condyles. It'll be in the spine as well. When you do a reconstructed pan from cone beam data, I'm sorry, but there isn't. I've looked at 28,000 scans. Probably 2/3 of those I've reconstructed panoramics from because it's a good way of looking at the data quickly. They never come to the same quality as a 2D conventional digital pan. That doesn't mean, oh, well, I don't need cone beam then because I've got a 2D pan. It means that it's another modality that's going to give you a lot more information, 3 planes of section and high detail. But the reconstructed pans from any of the manufacturers, I don't think, in my opinion, they actually stand up to a conventional 2D digital pan. The other thing that you can do is I use third-party software because I can't afford the software from every machine. So I have a different software with lots of funky tools in it. And this is a 3D panoramic, it's called a surface rendering. And you can see that there's information. I use this a lot to look at alveolar crestal bone levels. You can see that they're retained primary tooth, but there's bone loss around it in this region. So you can get some pretty interesting images from your cone beam data. Back to the 2D images, I give half-day lectures on panoramic where we talk about errors and we talk about concepts and we actually test you at the end. There's 10 multiple choice questions, but a lot of the questions will be something simple like this. What's the name of the anatomic structure? And I'm pointing to this little tiny slender radiopaque area here. Well, that's the styloid process. It's superimposed over the soft tissue of the ear, okay? To get back to our other known anatomy at this point, you can see the 2 arms of the hyoid bone. But these styloid hyoid ligament processes can calcify and they can get thick. There's 4 segments of them. They can calcify right down to the hyoid bone. And they could have symptoms related to them that you need to diagnose. So this is a conventional cephalometric image that was created and somebody overlaid, the various segments of the stylohyoid ligament process. It goes from the styloid process to the hyoid bone. Well, they can calcify in any of the segments. They can be interrupted, they can be solid, they can look very unusual, and they can cause problems. This is a reconstructed, what what I call a slab rendering. In other words, it's not a full thickness. You can see we've cut partway through the mandible, and in scrolling at say a 30 millimeter thickness, I can get back and make the mandible disappear so I can see the hyoid bone and the stylohyoid ligaments. And this is a very unusual case of bilateral calcification and elongation of every segment of the hyoid. They start out like this. You see the condyles. Hopefully even those who don't have CBCT yet will recognize that that's the condylar head. It's thin. It doesn't look like a condyle because it's at 1/10 of a millimeter thickness, but you can see there's something in this area on each side that looks unusual. Well, these are the styloid processes. We can thicken it out. We can apply a MIP tool if we need to, and basically bring those structures out. They also have an enlarged tonsillar area here. So I thickened it out to 17 millimeters, and you can see this still looks X-ray like because I didn't apply any tools. But after this, I did the MIP tool, and it was very, straight, elongated, and very noticeable. Then, of course, I went a little fancier and did the 3D image. I don't do this on every case for my clients, but I do the best imaging possible to embed in the reports so that they don't miss anything and they learn as they read the reports. Now, I could probably stop here and spend 5 minutes waiting for everybody to identify this structure, but I'm actually just looking at this curvilinear area right here. And if you had eyeballs, this is where they'd go. Okay, this is the infraorbital rim of the right orbit. There's lots of other structures on this pan that we'll identify as we go along, but the eyeball area is there, the sinus area is there, the zygoma, okay, and with the arch and the articular eminence, it's all piled up in that region, very important region. Hyoid again, of course. Now, this particular area of the hyoid bone is circled in yellow. I want to let you know right off the bat, you cone beam users out there, cone beams don't come with arrows and they don't come with circles. Okay, you have to identify the structure that you're looking at. This is a small field of view, a small FOV volume. This is the anterior mandible, fairly low down in the mandible, low enough that we actually pick up the hyoid bone in here. And I'm going to stop there for just a second. I know that by the time I finish these 2 seminars, you will still have lots of questions. I know because I teach this all the time in 1- and 2-day programs. And I'm also a dentist, remember, as well as a radiologist and educator. So I tried to think of tools that would help you understand what you were looking at. So I found somebody who could program, in the Mac OS operating system. I haven't found anybody to do it in, for the PC side, but in the operating system from Mac, if you go to the App Store, you'll see Scanatomy. Scanatomy, there are 3 planes of section on the front page. You click on axial, coronal, or sagittal. It'll bring up extra slices, and it'll ask you questions like this. It'll say the structure labeled number 3 is. So you go over here, you find the little 3, and you go, what's that called? It's in the posterior mandible. It's where the 5th nerve comes in, where I block my, the nerve all the time. Oh yeah, that's called the mandibular foramen. So if you got that far and clicked on that, you get a nice green light. If you missed it, you're going to get a red light. And basically, when you go through all of the planes of section and do all of the cases the first time, you'll probably get around 30 or 40% correct. But when you restart the program, it scrambles these answers and it scrambles the screens with different numbers. So you can't memorize it, but you will learn it. I've had people buy this application and text me and say, this is so much fun, I can't put it down. Of course, those are the guys that really liked anatomy, when they were in dental school. So I'm going to pause right there. That's what this little red symbol is. I think Jim or Paul, can you come on? I think you wanted to say something or show them another example of the hyoid in this area.
Yeah, Dr. Miles, thank you. We did have some questions coming in.
Sure.
One specifically about questions is with respect to the calcified stylohyoid and Eagle syndrome, do they warrant referral or simply notifying the patient of the possibility?
Good question. Okay. I was just looking to see, you know, what the timing and everything was. Eagle syndrome is quite rare, and there's actually 2 different types, and I'm going to go over those in the anatomy section briefly next time. The traditional eagles, William Eagle, you know, back in the late 1800s, sorry, he did a paper, and it was a fishbone. It was a neuralgic type pain on swallowing. Felt like a fishbone in your throat. You can replicate it if you're brave and the patient, you know, you tell them to breathe while you're poking the tissues, but if you put your glove finger back in the posterior part of the throat, go laterally, if you touch the ligament, you will replicate the pain. If they have pain on swallowing and they have symptoms, yes, that is a referral. I actually scrubbed in on a case, bilateral big elephant tusks, they look like, and I have pictures. Unfortunately, the surgeons didn't want to go intraoral. The ENT people went extraoral. I was up on a stool with a 35mm bellows camera and photographed the whole thing. And at the end, the gentleman who had all this referred pain and other problems from a second type of eagles didn't have any pain, but he was minus his 2 submandibular salivary glands because the ENT people, in reflecting the tissues, saw the hypoglossal nerve and didn't want to sever that, so they reflected it out of the way. Couldn't see the hyoid calcification or the styloid calcifications very well, so they sacrificed the glands. Luckily for the patient, no postoperative problems from the lack of salivation for at least 8 years while they followed him, and all his pain disappeared. Referred pain to the ear, the occiput. So he was a happy camper. So long answer, I apologize, and a little anecdote, but there are 2 types of eagles. If they're symptomatic, yes, both need to be referred. Some will go to surgery, some will go to ENT surgery.
Thanks, Doctor. I did have a question if we could see that on some imaging, and I do have my software up here, or the Vatech software here, and maybe we can kind of go through and look at that that ligament there. And I've got my 3D rendering here, and if we rotate around the side, we can kind of see our ligament running through the posterior part of the patient. But kind of what you showed on your screen there is going through your coronal or your coronal section. I'm going to switch this to my main view, and I'm going to switch my thickness up. And you had mentioned that you went to about 10 or 20, so I'm going to go through there and then kind of demonstrate our MIP tool to highlight looking at those hard structures or those calcifications there. So this would be the sorry, this is our stylohyoid ligament here.
Yes, they're bilaterally calcified, all segments. It looks like as you scroll, it looks like both of them go up to the styloid process. Next week, you're going to learn that ligament actually passes between the internal and external carotid arteries where they branch in the neck. And if that patient that you just showed me there turned his head, they would either have referred pain or sometimes syncope. And we'll talk a little bit more about that next week. But that's a very nice rendering. Thank you for sharing that.
And then comes down to our hyoid bone down there. One other thing I picked up on, you were looking on your different PANS images, and you had that cyst that was in the sinus, and I have my 3D rendering right here, and I believe there was something similar that we have in our section window down here going through our rendering here of this little dome shape here, something in the sinus, and we'll talk maybe more about this after the session at the top of the hour of how to kind of navigate through our 3D pan tool. We did have another question earlier on what do you prefer, the conventional pan or CBCT pan, and you did answer that during the session there. So, but those were 2 kind of questions we had come in, one about the dome and then one about visualizing and using that MIP tool to visualize those calcifications or harder structures through there.
Sure. So. Okay, thank you.
Gotcha. Well, let me, I'm going to send it back to you, and we'll make you the presenter again, and we can jump back into your presentation there. But yeah, those 2 questions that came up.
Oh, great. Thank you for that explanation. You know, I actually, we've only sort of looked at 2 webinars, but I've got 2 additional ones that I think might be useful, and you can maybe poll the audience if they have an interest. But what I do is I go through the anatomic areas of the scan and tell you what are the important findings in each of those areas. For instance, cranial cavity, paranasal sinuses, and nasal cavity, the airway itself, and temporomandibular joint, cervical spine. So I've done that for 10 years, okay, so on the speaking tour, and I actually have it in the textbook to show you, what you really do need to see.
Right. We do get a lot of questions on that for our doctors. So I'm going to send it back to you and we'll continue on. Thank you.
Thank you. I'm gonna charge Jim for 4 minutes of my time now. No, I'm just kidding. Typical educator, I want more time than everybody gives me. If you are looking now at the screen with the 2 yellow arrows outlining a radiolucent area, kind of looks like a teardrop shape or inverted pear-shaped area here. There's a lot of people that will not know what that structure is, and if you look on the opposite side, you can see it over here. It's a very important landmark. It's the pterygomaxillary fossa, or fissure, and it actually is the boundary of the posterior wall of the maxillary sinus. Now in the 2D world, when you're looking at these pans, like I said, a lot of these structures overlap in this molar region or the zygoma region on the patient. So if you don't know that this is the sinus, you might think that the sinus ends here because it's a very apparent sort of radiopaque wall or line. Well, this is actually the anterior part of the zygoma. So this is a very important landmark. You need to remember it, especially if you're trying to look at the entirety of the maxillary sinus. But if you move to 3D, you'll never miss anything in the sinus or the nasal cavity. And speaking of the nasal cavity, what I'm pointing to here is actually the soft tissue outline of the nose. Okay, so these would be the ala. Okay, this is called the columella, this little conical shaped area here, and this of course is the nares. This is where you put your finger to clean it out. Oh wait, we're not supposed to do that because we're in a COVID environment. So I love how they say don't touch your face. What they really mean is don't rub your eyes and don't pick your nose. So sorry if that grossed anybody out, but maybe some of you are laughing. In the CBCT world, you can get thin slice information and you can see the soft tissue outline extremely well in any machine. Vatech can show you the same sort of images in theirs as well. But I want to show you a couple landmarks just briefly. We got soft tissue outline of the nose and the lips. We've got the nasopalatine canal, and the foramen would be here. A lot of you learned it as the incisive foramen because it's behind the incisors, but the correct term is nasopalatine foramen. You can see vertebral bodies, all right? You can see a big sphenoid sinus. I know I'm in the midline when I see the nasopalatine canal and the vertebral bodies kind of looking like vertebral bodies. These structures back here are actually the spinous processes, and we'll do a lot of that next week. So you can put on or thicken and make it look more X-ray-like or cephalometric. You can still see the soft tissue, but in some third-party softwares, you can really do a job. I've had cases where the doc will say, oh, the patient's having pain in the left mandible and there's a big hard bump. And I look in the mandible, I don't see anything. But and it's not this patient, but when I put the soft tissue on, it was a big old lymph node and it was hard. And yeah, I didn't have the patient there, but I can show you in the soft tissue the outline for that. I had to put the black box on here to make this anonymous because these can be made and rendered so that they look exactly like the patient. All right, back to the 2D anatomy. I showed you this area earlier. I said this was the infraorbital rim. You can see it here. But in this case, what I'm actually trying to point to is this little thin radiolucent line that comes across the sinus space. And this is actually the middle meatal space, and it's outlining the top part of this inferior turbinate. I don't know if I put it on. Yeah, I did. So this is the inferior turbinate, and this dark line is actually the meatal space. In 3D cone beam images, when you see the nasal cavity and the maxillary sinuses, you can always tell there's a problem, because there's an opening to drain stuff out of the sinus into the nasal cavity right at the middle meatal region, the middle turbinate region. It's called the ostium, and we'll see that later. If that ostium is blocked, if there's sinus crud, you know, some schmutz, there's a good word for it, some schmutz in the sinus, and it blocks the ostium, then you can't get drainage from the other paranasal sinus spaces. So if you cut off at maxillary, and that's where your expertise lies, but they've got a problem, you know, they can't breathe, they're stuffy, they've got pain, they got referred headache, whatever, you may just by the pan say, you know, I see enough change in the sinus space, the maxillary sinus space, maybe we ought to get you an ENT consult. And that'll become much clearer in future webinars. All right, so that was panoramic. You could see how difficult it is to see these structures, but when you get thin slice multiplanar views, MPR views they're called, this is the maxillary sinus nasal cavity ethmoid air cell complex region. You need to understand this. You need to know what normal looks like and what abnormal looks like. And again, I do lots of lectures in those areas as well. But you can see that the inferior turbinates now kind of look the way they should in the patient if you had a thin slice. The middle turbinates are here. This is the inferior turbinate in the sagittal view, and you can see very nicely the meatal space above and the meatal space below going back into the airway. There's only two ways of getting junk out of your sinuses, and that's to spit or swallow. Okay, everything has to move through different openings. These all communicate to the back of the throat to be spit or swallowed. Okay, can't do it any other way. So that's the inferior turbinate as it looks on a coronal plane of section and a sagittal plane of section. And that's what it looks like on a panoramic plane of, image. These are three-dimensional structures piled on a two-dimensional image. These are anatomy the way it's supposed to be. Thin slice, multiplanar, you can see everything. All right. This is the artifact I was telling you about earlier. This is the inferior border of the left mandible. This cortical border here is ghosted on this side. So this sometimes can be interfere with your diagnostic capability, but it's not really an anatomic structure except that it is the ghost image of the left mandible superimposed on the right. And the ramus, all of this part, is all of this part. So the ramus actually is all of this across here. Now, here we go with our 3D reconstructed pan. And just so I don't get my, my colleagues there from Vatech all excited and mad at me, this is not a Vatech image, okay? This is from another manufacturer. This is a MIP image, however, a maximum intensity projection. It actually is pretty good at gross sort of outline to see what's happening, what teeth are restored. It has some value to it. I use it to count teeth, to see teeth, to see what teeth have been treated endodontically. That's much different than what you see here on a 2D pan. So I don't think any panoramic reconstructed pan lives up to a 2D digital. Whoops, sorry. Now, what we're pointing to here is actually the hard palate. Hard palate can be a double shadow as well, and I don't have the opportunity to explain how that occurs because it takes several slides to explain a simple concept. But that's the hard palate, and then going into the soft palatal shadow on 2D. There's the soft palate as well on that side. The hard palate, of course, in a cone beam image is much different. And this is a small field of view that cuts off, right partway through the maxillary sinuses. These are the inferior turbinates. One space is larger than the other. This inferior meatal space is bigger on the left, which means that this is a hyperplastic right inferior turbinate that has narrowed the adjacent meatal space. But that's all you've got. If you had a larger field of view, or if you had changes in some of these areas, you might have to take a larger field of view to satisfy yourself that you've diagnosed everything in the scan. Or you could say there's lots of opacification in the maxillary anther that are visible, patient being referred to an otolaryngologist for clinical and endoscopic evaluation. And of course, they would look at the rest of the paranasal sinus spaces. This anatomic structure, it's not this, it's these. I don't know why I didn't make it plural, but we're just pointing to the vertebral bodies in this particular image on the patient's right-hand side. When you do see vertebral bodies that are more apparent, look at them. Look at the spacing in between them. Look to see if there's any osteophyte formation, if there's any holes in them that can look like subchondral cyst formation, because the cervical spine has the same osteoarthritic changes as the condyles that you learned in school, but then forgot about the spinal changes. In cone beam CT and thin slice, and you can see the difference. These are spinal columns on the pan, and this is the spinal column in thin slice sagittal view. This is actually C2. This is vertebral body C2. It does not come with an arrow. The arrow is pointing to a small subchondral cyst in the dens portion of C2. So I would look for other osteoarthritic changes. This is the anterior arch of C1, which is called atlas, of course, and this junction is called the atlantoaxial junction. Right in this area, I see a lot of loose bodies, and they can cause referred pain. They can cause neck pain. And loose bodies, you learn, some of you, actually occur in the temporomandibular joint region. Well, here's another area. And when they refer pain, the diagnosis gets very difficult. This is a young individual, though. This is unusual to see that kind of change in the dense portion. But this patient has sinus change in the frontal sinus here, the ethmoid air cell complex, and it will eventually possibly go into the sphenoid sinus in this region. This is called the ostium, the sphenoid ostium. So there is a communication between all of these, and also from the ethmoid air cell complex to the middle part of the nose, again, to get junk out of here to go down here. And you're going to name all these structures for me eventually. Okay, if you missed this one, you got to go home. Everybody should know that this is the external auditory canal, or opening for the external auditory canal. There it is on the patient's left, and there it is on the right. Well, it looks a lot different on cone beam data sets. This is the external auditory canal. This, of course, is the condyle. Again, if you miss that one, you have to just sign out, go home, and take up law. Just kidding, guys. This is the mastoid air cell complex. If you're taking temporomandibular joint views, you got to pay attention here, because I see mastoiditis fairly frequently, and I'll show you that in a different lecture. But right here is a loose body. Or is it? This is a thin slice sort of view. We got to make sure that it's a loose body. Well, I have tools that I can click on, drag them out, and get a 3D rendering. And if you're not impressed by this, I don't know what will impress you. There's the loose body. It is. It's a little piece of cartilage or bone that is sitting in the joint space. The inferior belly of the lateral pterygoid actually inserts right here into the condylar neck area. So it could be that it pulled away some tissue and eventually got hardened. This is the external auditory canal in 3D. This is the styloid process, probably calcified, because normally it's only about 2 or 3 centimeters, 1.5 to 2 centimeters long. And there's the mastoid air cell process. So you can do everything from thin slice to full surface 3D and everything in between. And they didn't have a fracture here. This is just where I cut off the image when I was doing the sculpting. All right, we're getting along in the talk here, so I want to just kind of wind down here. You'll see this repeat several times. Hopefully by now you'll realize that is the soft palate. Okay, I think it stays stable in the next one. Yeah. So the soft palate is a soft tissue shadow overlying this part of the posterior part of the ramus. I don't apologize for repetition in any of these talks, because some of you don't get it the first time, and you get it the second, third, or fourth, or fifth time. So I do have repetition in some of these talks. If I were to show you in a thin slice sagittal plane of section the soft palate, it would be right here. So it looks quite a bit different, but this would, in actual fact, be more of its shape. However, it's only 1/10 of a millimeter. Of course, this goes, across the whole posterior part of your throat area. So, these structures you have to learn to identify. This is the sella turcica. This is the sphenoid sinus. This is the slope of the sphenoid bone. It's called the clivus. Anterior arch of C1 and C2, Den's portion in here. So you got a lot of learning to do, I think. Now, the shadow that we see here is actually outlining. This is the soft palate, remember, and then this tissue down in here is the posterior portion of the oral pharynx. This is the posterior wall of the oral pharynx. So this is the nasopharyngeal to oropharyngeal airway area. Lots of tools, and you can get, those of you who have the Vatech machine that does airway study, they have some tools they can demonstrate for you there. This is not theirs, but this is a type of airway that you get where red is the narrowest area, and you'll see multiple views of it, but it'll also give you an automatic measurement in those areas. You should ask your reps about those tools if you're getting into obstructive sleep apnea or sleep disordered breathing. The next area I want to show you is actual finally getting to the maxillary sinus, okay? This is the lateral wall of the nasal fossa. This is the inferior border of the sinus, and it doesn't end here. It goes all the way back to the structure that I showed you earlier, the pterygomaxillary fossa. So very nice view of the sinus. They look patent. They don't look like there's a problem in it, but there's turbinate, there's zygoma, there's some nasal structures sometimes superimposed. So it's a difficult area that most people skip over unless it's something extremely apparent in the maxillary sinus. You can't skip over it in cone beam. With these particular views, in the axial view, you can see that we're midway through the palate. This is probably a little torus here, and you can see complete opacification in the inferior portion of these sinuses. This is the condylar neck area, just going up towards the condyle. This is the styloid process, mastoid air cells. Over here, this is much more understandable for most of you, especially you 2D users. This is a thin slice coronal view, MPR view, showing that the patient's right side, which is over here, and we'll talk about conventions after, down the road in the seminar series. This right maxillary sinus is almost totally opacified. And oh, by the way, the middle meatal area and where the ostium is right in there. So there's ethmoid air cell mucosal change bilaterally, more on the right. This is blocked. This one's probably on its way to getting blocked. So this patient, although they don't have much change in the inferior portion on the left maxillary sinus, they're on their way to a pansinusitis. And by the way, this is what a deviated nasal septum looks like. So these views of the paranasal sinus spaces are unbelievable. And we have to either make an ENT doc your best friend or learn something about these spaces so that you know when to refer. All right, the next structure, showing you the zygoma again, but on the opposite side this time, showing how it superimposes over part of the sinus space. The sinus actually extends back to here. So there's the sinus, and you can see the overlap between the two structures. All right, so I'm going to stop here. It's a little bit early, but not much. And I know it was a lot of information. I also know that Vatech's probably recording this, and you may be able to avail yourself of the structures in here with the verbiage to go along with it. But down the road, what I'd like to do at some point is actually get to a point where I show you how to review your volume. And of course, those of you who haven't adopted cone beam yet may not have much of an interest in that, but those who have would be very definitely interested in that. So I'm going to close out my presentation. I don't need the hits, by the way, but if you go to drconebeam.com, there's videos, short videos. There are at least 30 articles. There are links to my textbook, the Anatomy, a couple of other things that I've put on there. I don't sell it on Dr. Cone Beam, but I do have links to some of those things. If there's anybody out there that bought my Atlas, the Cone Beam CT Dental Applications, thank you very much. It's in its second edition, and we're going to get to a third if we sell out the second edition, and we don't have far to go. So please visit the site. Lots of good, useful information, and I think you'll know a lot more once you visit that site. So thank you very much. I'm going to close there. James, if you would take it back and we can answer some questions for the folks.
Certainly, Doctor. Thank you for your time today. I think one of the things that I learned is there's a lot of many similarities of the PAN to the CBCT. It's just a matter of understanding and learning from the basics to get to how do we quickly review, or how do we review in a CBCT and understand those structures. I know your Scanatomy app, a lot of us have purchased that, and it is a good way to learn just through repetition and understanding and seeing different views. Also leading into from today's session, next week we're going to go over more details in the CBCT data sets themselves, looking at the axial, coronal, and sagittal slices, and building on today and today's information there. We did have some questions coming in. I think Paul's been kind of looking through those questions. Paul, what are some questions we had for Dr. Miles?
Just looking through the questions here, we got a lot of questions coming in. Let's start with some of the basic ones. Dr. Miles, do you see offices using patient consult forms when scanning?
I'm not sure I understand the question. What do you mean patient consult forms? Do you mean a form that is actually written as a
patient consent forms? I apologize.
Okay. There should be a consent form generically for any radiographic procedure in the dental office. I don't deal directly with the patient, obviously. I get anonymous data, and then I get a notification of that anonymous data. I look at the cone beam data. I put arrows. I interpret what I see and put it all in a report, and then embed some of the images that I capture in that report. But I think there should be informed consent for any dental procedure that is potentially harmful to the patient. Now, having said that, cone beam is probably one of the kindest radiographic modalities that's out there. The dose is extremely low, especially compared to conventional CT, and has gotten so low that it's actually, in some cases, lower than a full mouth series and a conventional film-based pan. So it's, I don't see the consent forms. You should have one when you're doing the procedure, but more importantly, you should examine the patient to determine the need for that, cone beam scan. It's going to be real hard for you to defend, well, we take one on everybody, and well, okay, if it's baseline and you can got it, you're going over it and using it for your treatment planning, fine. But if it's, well, we just take one, because it's such a great modality, that's not a reason. You have to have impacted teeth, missing teeth, pain that you can't ascribe to, or find on intraoral or panoramic radiographs. So there's a lot more thought that has to go into it, but certainly consent is a part of that.
Got it. Thank you. Couple different doctors asked about, should I send all CBCTs, have them all read as a standard?
Well, my standard answer for that is no, and I'll tell you why. You have to think about the office procedures and flow. And even those of you who are thinking about maybe purchase of a scanner, you have to look at the tasks that'll help you be a better dentist by using that modality. So here's what I tell people. If you're only taking 1 or 2 scans a week, and primarily it's for your implant planning, and you take them 1 week and you surgerize, the following or 2 weeks later, you probably can train yourself to be efficient and knowledgeable enough to pick up abnormal in the scan data and refer it, okay? If you are taking 10 scans a week, you don't have time, because it takes me anywhere from 5 minutes to 25 minutes to look at a scan, okay? It doesn't matter what size. There's a lot of information in. I have to capture images. I have to put them in a report. Well, if you're looking at, the same scans, and you have to record in your chart, capture screenshots to put in your patient electronic record, maybe make a formal report or at least chart notes, you're talking time away from the chair where you actually make most of your money. So if you're taking 8 or 10 scans a week, by all means, I'd get them out, because you don't have the time to look at everything. you're going to miss something, and then the patient, if harmed and angry, will come back, with their lawyer to talk to you. So, and I know that because I do a lot of expert witness things as well, and there's a lot of people that don't look at the entire scan. So,
right. One more here. What data does the radiologist need, and then maybe Jim, you can help with this one. How do you send it to them?
Okay, those are two great questions, and I'm a little different than my colleagues. When I take on a client, I'm your radiologist. I just practice in a different location. I build a relationship with the referring doctor. There are services out there that you just submit the data, upload it, they triage it out to whoever's available. So you get a different reader, on lots of different scans, unless you're able to specify the same one. And so it really is a matter of just uploading to, in my case, I just have a server. I send you credentials to log in, all protected and with a user ID and password, so that you can export the DICOM data and just drag it to your folder on my side that you see. When I get notification from you in a different computer, I basically get that information and then bring up the scan into my software and do the report. Now, what data? I'm different than most folks, again, because I've built relationships. I'm not just a reading service. I only ask for the patient's name and the age. And the reason I do that is I really don't like to be biased when I'm looking at the scan. I'm looking for everything you're not. I'm looking for occult pathology. I'm looking for the things in the scan that would be important for you not to miss, important for you to refer, and important for the patient to get the correct treatment. So let's say in a week, I read around 30 to 40 scans a week, okay? Sometimes less, sometimes more. But if there's 10 scans with important things in them and I know they're going to be referred, there's a lot of times I pick up the phone and I'll call the doc and say, hey, you're going to get your report uploaded back to your folder, but this patient really needs to see an ENT doc as quick as possible, or an orthopedist, or whatever it is. And I think, that way it is building a relationship. Some of the docs like it, some of them don't. Some of them want to send me big, long histories. I don't need that. You're the one treating. I'm just the next pair of eyes to find the things that you're not looking for, so that I reduce your risk and liability.
Thanks, Doctor. Yeah, I can address the how to send, or at least how to export out of the Vatech software. So, Doctor, you really don't even need the viewer. You just want the DICOM data in its raw form, not just plain digital DICOM.
Yeah, exactly. And I can tell you that was a good comment for you to make, because it triggered one other thing. Number one, most manufacturers, I think you guys do it better than most, thank goodness, but most manufacturers, they never teach the office, any member in the office, how to export DICOM data as raw data. They always say, oh, you just burn a CD-ROM and you send it with the viewer. Isn't that convenient? The viewer for a radiologist is useless because it only has limited tools in it. And I'm not talking about your viewer, I'm talking about anybody's viewer, okay? I mean, there's third-party software viewers that you can download for free and look at stuff and do simple measurement. But if you're really gonna look at the scan data, we need all of the DICOM data so that we can do image processing and apply the tools to make much better observations, so that you make better clinical decisions.
Thanks, Doctor. So yeah, kind of let me demonstrate on our software how we do that, because we do get a lot of questions when we're at offices of how do we share images with other offices? What should we be sending? And I always say, if you're sending this just to the radiologist, they just need the DICOM data. We can find our CBCT here, or let's go to another one. It's going to be right here. I can right click and I can go down to export. Once I click on that, it's going to gather all of the DICOM files and then ask them where do we want to export those to. We usually export them to a folder on the desktop and then ship them to our radiologist. You can do local disk. If you did want to burn it on a CD or DVD, you can do it there. Once that's been exported, I can go to my folder here, and I've got, let me find my folder on here. We've got an export folder that I've created. And as you can see in here, this is going to be just all of my DICOM data. So Dr. Miles, I understand you're just taking this, putting it into your software that you use daily for your radiology reads is one way. Now, if we are sending this to, let's say, a colleague or another dentist, and they do want the viewer, we're going to go ahead and open up our CBCT scan. I'm going to go ahead and go to main menu up here, go down to export. And the nice thing, or one of the I think features on the Vatech software, is I can still do DVD or local disk, but it always gives them the DICOM. So even if we do accidentally send this format to my radiologist, we have the project file and the viewer. If I click save, that's going to save that and bundle that back into my folder here on my desktop. Let's go to our export. And it's saved a little bit different. You can see I have my launcher here, but it actually still has the DICOM data that can be separated out of there. So 2 different ways to send it. One extra step sending it from the 3D viewer. But if you're not sure if the office needs a viewer and the DICOM, a lot of times I'll just send it this way, because then they have their choice of opening either one really on there.
Okay, James, that was you explaining, correct?
That was me explaining, yes.
Okay, can you back up one, just back up one before to show me all the things that are bundled with it?
So everything that's bundled with it.
Okay. No, just wait. Okay, 13 items. Now, can you highlight all of those and then do properties and tell me how big that is?
Yes.
Not just that. I want all, yeah, exactly. I want all of them.
Let me go to the whole folder and just do properties here.
Yep.
Which is going to be our 659 megabits.
Yeah, and you see, you know, I run my own server. I don't want all of that.
I understand.
The point I'm getting to, and I love your explanation, is
right.
I get these things. The first thing I do is, if somebody sends me all that, I dump everything except for the DICOM data. So please, as a plea to the clients out there that are going to use a radiologist, whether it's me or someone else, just send them the DICOM data. Okay.
Perfect. Which cuts the size in half here. You're correct there, and it's one step easier on there. Perfect. Thank you.
Okay.
Paul, what other questions we have?
Tons here. What field of view do you recommend as far as the scan size field of views? Do you have a particular size you recommend?
Are you looking? I've got one on here, Paul. It says a doctor's interested, general dentist with interest in TMD and airway. And Dr. Miles, you mentioned getting up into the ostium and superior sinus. So I have on screen a 17 by 15 scan, which we can see here that shows the patient's soft tissue profile, shows down in the highway bone, all the way up into the superior sinus, and also the condyles there. What are your thoughts on the need to look into superior sinus and for TMD and airway?
Spoken like a true educator salesman. There's no such thing as a superior sinus, but I know what you mean. I hope the people listening do. We'll educate your staff members there too to call it by its proper names. However, if this gentleman wants to do TM joint and he does airway or whatever, he needs this size field of view. I think that you, like many other machines, have variable size FOVs, correct? And they're selectable?
They are, yes.
Okay, so again, what it boils down to is your task. If someone's doing an implant, a lot of times they'll feel they only need, you know, an 8 by 8, and they get all the dentition and it cuts off, you know, just south of the condyle. Here's a little bit of a proviso for those implant docs that think I need less size field of view. A lot of times in an older patient that's had an edentulous space for a long time, when you restore them to function and put them in occlusion, they haven't bitten on that area for a long time. And if they have a pre-existing problem like osteoarthritis of the condylar head, which is very simple to see on this particular field of view, you can say to the patient, Mrs. Jones, I'm going to restore your bite here. You're going to chew great, but you've got a little spur on your condyle on the opposite side, and it could flare up, you know, because you haven't been functioning in that area. So this is again opinion. My opinion is that anybody that, and this implant is one of the most popular uses for CBCT, anybody that's doing implant needs to see the condyles, in my humble opinion. And this is based on my years as a dentist as well, because it's a lot easier to say to them, you might have a problem, and treat it very conservatively than them coming in and say, Doc, I can chew real well here, but how'd you make my joint hurt? Now you're the bad guy. So my feeling is that if I had a perfect world, I'd probably go with the largest field of view that's going to encompass all the tasks that you're going to want to do for cone beam. Even the endodontist these days, and Tom here in his own facility goes much larger than he initially did for endodontics, because they get patients with a problem in more than one quadrant. Well, why would you have to sit them down again, take another small field of view, when you could have captured at least all the teeth in the first scan? So, you know, everybody has to decide what the tasks are that they're going to do, and then talk to the reps and say what field of view would be appropriate for me. There is no one size fits all, unfortunately.
Right. Thank you. Paul, what do you got for us next?
Somebody's asking where they can buy your book.
Yeah, it's actually from Quintessence, and you could go in there and search by author or book title. But if you go to drconebeam.com and just follow the links, it will lead you to the Quintessence site. And here's the deal. You guys aren't ready for this. I wasn't going to share this, but the book originally retailed for about $142 because they're trying to sell off the remaining textbooks to get to before we go to the third edition. It's now selling at the unbelievable price of $32. So some of you will take advantage of that, I'm sure. And if you do, thank you, because my kids need shoes, all right, with it.
And actually, somebody else had asked the name of the app, your app.
Oh, it's called Scanatomy. Scan and then anatomy at the end of it. Thank you for asking. And yes, most of the people at Vatech, when I showed it to them, bought it and said, this is great. You know, I can show my, you know, the potential customer here that there's a simple app that's very reasonable in cost that helps them get through their volumes.
Got it. Somebody else, this is an interesting question. Can you suggest a book, a textbook or to study anatomy and CBCT?
You know, yeah, unfortunately there isn't one that's specific to just cone beam CT anatomy. Anybody out there wants to do one, I'm sure it'd be extremely popular. The very first chapter in my book currently is all anatomy, and it's thin slice, all planes of section, thicker slice called slab rendering, and full surface color 3Ds. You know, just walking through a plane of section, doing all those things so that people understand what anatomy is they're looking at. So I'm not trying to sell another book, but there is a very good chapter there, and I don't think anybody just has a book devoted just to cone beam anatomy CT.
Got it. Somebody else had asked about the MIP tool, the maximum intensity projection. Jim, can we maybe show that?
I think you are showing it right there.
Different ways. We have our 3D rendering here, which Dr. Yu had showed the virtual rendering where we're adding bone to the crestal ridge there. We do have our MIP tool in the 3D virtual rendering, or I did actually have a question that came through about showing the 3D pan, and I'm going to kind of click over there. And here's our reconstructed pan that we had. Doctor, I know you showed one, basically the same tool. It's a click of the button to get over to this reconstructed pan or to add this to our harder tissue here. What we did in the first pause or break is we went to the coronal view here and then enlarged this, and we right-clicked and changed our thickness out to 10 or 20 millimeters. And then what we did is we added our MIP, or our maximum intensity projection, to, and Doctor, you can correct me if I'm wrong, we're visualizing the harder tissue and any calcifications within our scan there.
Yes, and this is extremely important for any of the carotid plaques or any of the other calcifications, which I'll identify next time as what we call medial arterial calcifications, which are actually very prominent in undiagnosed or uncontrolled type 2 diabetes mellitus. So for all of you out there, we've actually got ways of almost screening for a diabetic patient if they're not sure they have it or not, and you will be very amazed. But this tool and the way that Jim is using it by scrolling through what we call a slab rendering or a thickened set of slices is one of the best ways of finding those types of calcifications, and I'll show you plenty of them next time.
That was another question we did have, is how do we visualize carotid arteries or other calcifications? So that's something, like I said, we'll be touching on in your next session there.
Yeah, you only gave me an hour today, you know. I like to tease these guys, all you colleagues out there. Yeah, you got to keep these vendors straight. You guys are doing a great job, by the way, demonstrating that.
Thank you, Doctor. It's been a pleasure working with you on this project.
Absolutely. Somebody else is asking, do you do implant consulting on difficult cases, you personally?
Yeah, and thank you for the question. I really don't, and it's because I read about 120 to 100, well, not now, not with the COVID-19 virus, but I read about 120 to 160 cases a month, and I don't have time. On a rare occasion, if I've got a client that, you know, has been with me for a while and they can't find the canal, I may help them map it out by doing image processing and applying some of the tools that I know how to use a little better than they do, but I don't plan implants. There are some services that have people that will do that with you, but I'm not one of them. I'm sorry.
Okay, here's another one. Pretty interesting question. Do you think it's beneficial for you to see an open mouth CBCT as well as a closed mouth, or your opinions on that?
Well, since I don't want to go down the whole I've moved the condyle into a perfect position argument, because that we'd be here for the next 2 hours. But I can tell you that visualization in 3D surface rendering is the best way, I think, to look at condylar heads and position. And open is a lot easier to view the entire condyle than closed. So if you're having difficulty determining you know, maybe the direction of where you think the disc might lie, whether you think it went off laterally or whether it's anterior or wherever, you can get some information from open and closed. But by the time you get to, I'm doing open and closed to see, you know, help my diagnosis, you might as well even just consider magnetic resonance imaging and actually see the soft tissue, which cone beam can't do in the disc region yet.
So that would be more of an MRI, correct?
Yeah, that would be using a different modality, obviously, to see muscles, to see the disc position, and see where it's displaced. Thin slice multiplanar views, especially sagittal, when you get to compare one side to the other, give you a lot of information whether the joint space is increased or decreased on one side or the other. So cone beam CT will give you a lot more information about temporomandibular joint problems. But if it boils down to, I want to know if I did something that put the disc in a better place, you've got to do MR.
Perfect.
Great. Well, you might have answered this already, but are we legally responsible to send CBCTs for radiographic interpretation to a radiologist?
No, you're not. You're legally responsible for looking at the entire data set and identifying the I don't knows and referring them. You can't abrogate that responsibility by saying, I'm only doing an implant, I don't have to look at the rest because I'm not trained. If you're going to take the volume or order the volume, you need to be responsible for all the data in it, and there's no way around it. Unfortunately, a patient can't sign away negligence. A patient can't refuse treatment or what you want to do unless they consent. Those two things are tied together, and if you haven't looked, how can you inform? If you haven't informed, how can they consent or refuse? I mean, it's as simple as that. So
Right.
I do whole day lectures on risk and liability. Well, not whole day, half day lectures, and that question comes up all the time. And just if I can give it 10 more seconds of explanation, I went and spoke to the American College of Legal Medicine way back in 2011 or 12, and I showed them a screen in PowerPoint that said, I have the patient sign a form that says they refuse to have my scan looked at by a radiologist or anybody else, and I as the dentist that they signed for am only responsible for the implant. And we only had, there's 200 DDS-JDs in this group. There's a much bigger medical side, of course, but of the 40 in the room, there wasn't one person that wasn't laughing hysterically when I showed that screen. And these are DDS-JDs, okay? These are they're looking for ways of helping our colleagues stay out of trouble, and they all said the same thing to me: a patient can't sign away negligence. If you haven't looked, you can't inform. If you can't inform, they can't refuse, right, or consent.
Here's a good question. With a CBCT, the bone height surrounding teeth often looks low, as if the teeth are not covered, especially on the facial surface. How accurate is the bone height covering circumferentially around the teeth?
The height and the thickness of the bone, especially when you get to see it in 3 planes of section, is as precise as you're going to get. So yes, you do see a lot of teeth that look like they have fenestration and very thin covering of bone, and indeed most of them do. There's a point of diminishing returns when you're doing the surface rendering and you're changing parameters like opacity and transparency. There's a point of diminishing returns because you can make bone disappear very easily, and you can add soft tissue or other artifact that obscures the look at the height of the bone. So again, it can't do it all. I would correlate these changes you see in CBCT with your intraorals images and also your probing depths and intraoral exam. But that's a beautiful example of showing you just how thin that bone is on the facial aspect of that root surface. So it's pretty darn accurate. Now remember, the limitation is the voxel size. If a structure is smaller than the voxel size, you're not going to depict it in the scan. So it's as precise as you're going to get.
So I know on your panoramic and 2D imaging, doctor, there's always a distortion. Could we say that the CBCT is almost a 1-to-1 correlation? We don't have to go through and basically when I take a measurement, that's going to be a true measurement on my CBCT.
It's only dependent on how much shake is in your mouse.
Actually, I can see right here. I need to move just a little further back. There we go.
Yeah. Perfect. So, and you said something that triggered me. It's not that it's that you think it's, or that it approximates 1-to-1. It is 1-to-1. In other words, it doesn't matter whose scanner you buy. Every reconstructed CBCT scan is reconstructed in a precise 1-to-1 ratio. So, for instance, Jim, I'll ask you to do something there. Take a screenshot. So, well, let's just all remember that's 8.1. Okay. Now, take your lines off of there. Now, make that image twice as big. Make it fill the screen. Just magnify up, 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 up. Okay. Now stop. Now go ahead and measure it again. You won't get precisely the same spot, but you'll get pretty close. 8.2. Okay, so this is such a precise measurement, and everything is in a 1-to-1 ratio that it doesn't matter if you're working big or small on the screen. your measurements are going to be within 1/10 of a millimeter accuracy.
Perfect. Thank you.
Okay, that's because that's the slice thickness. Okay,
Right.
millimeter usually.
A question about the reconstructed Panorex. For insurance reimbursement purposes, can you still follow the ADA code for Panorex if we actually had it reconstructed from a CBCT?
Well, you could, but if you're also charging from the for the CBCT, then no, you gotta charge for one or the other.
Right.
And here's the other thing: if you're in a position, and again, it's patient dependent, but let's take a 9-year-old, okay? You want to do a growth and development assessment. So you take a pan. You can probably see what teeth are developing, where they are, if they're all coming in properly. If you say, well, you know what, I can get a pan from the CBCT, and then I can establish the growth and development of this patient, even though the dose is real low, you can't justify taking a cone beam to make a panoramic when a straight panoramic would do. I hope that answers the question. You basically can only charge for the cone beam and the evaluation of the cone beam. And that's the other thing. Most dentists are out there thinking, well, here's what do I charge, and you know, what do I get for the fee? This is a procedure code. Here, I'll put it coded and whatever. That's not what you get paid for. I'm sorry, guys and gals. You get paid for interpreting what's in the scan. You actually, even when you take a bite wing, you're not paid for taking the bite wing. Even though there's a procedure code, you're paid for looking at it and making a diagnosis, okay? And people lose sight of that. The dentist is the diagnostician. They're not the technician. And just because procedure code pays for the thing, that's not what you are actually, you know, being reimbursed for. So you got to remember the patient on the other end of that tooth.
Perfect. Thank you.
Well said. Thank you, doctor.
You're welcome.
Doctor, I think we're getting about down to the bottom of the hour. There are a few questions we didn't get a chance to answer. If anyone, we will reply to you offline if we didn't get to answer your questions. Doctor, let's talk about what we have coming up next week, kind of building on this week's seminar for next week's session.
What do you want to know?
All right, so we're looking at more anatomy in the CBCT 3 planes of section, the sagittal, the coronal, and the axial, and really going through a deeper dive into anatomy. Is that correct?
Yes, and in that dive into the anatomic structures, we also, I pepper it with some cases and important things and why we see them in the various plane of section and why we shouldn't miss them. So it really is supported by some of, you know, by the cases that I've seen. So you'll learn the anatomy, that's what it's mostly about, but there's also, here's why you need to know the anatomy, because some of this pathology appears there, but it really just touches the surface on the, you know, pathologic conditions that you will see in each anatomic region. That's a whole, those are at least 2 to 3 more webinars, so.
Perfect.
Right.
I know we did have some questions on your app. Here's the app right here, Scanatomy. Everybody will get a follow-up email with a link to Scanatomy. It can be found in the App Store on Apple there. Dr. Wee, thank you for today. We are going to be recording this session. It can be found on the Vatech webinar session as a review. We cannot download it, but you can go and review today's session and all of our past sessions. Also, there is no CE credit for today's session. And lastly, for service and support, you can go to vatechamerica.com, the Q&A, also to find out more about what we do for our training protocol after you buy the device. We want to make sure everybody is, staff are properly using it. Doctors are comfortable using the CBCT software. You can find a little bit more information about that on there. But I want to, Doctor, personally thank you from the Vatech family for taking time to develop this webinar. And also, thank you for working with us today on going through your presentation and the software.
My pleasure, Jim, and I just want to add that we're working on, and we'll probably be able to offer, that's why I thanked Horizon today, a CE credit for next week's webinar. I'm pretty sure that will be in place for 1 hour CE credit.
Gotcha. And we will have that answer when we get there. So
Great.
Everyone, thank you for tuning in. We look forward to seeing everyone next week, Wednesday, April 6th at noon Eastern. Dr. Miles, Paul, thank you for your time and stay safe and have a great week.
Thank
Thanks
you very
again.
much.
Thanks a lot.